later, if that same stage 4 pressure injury reopens, it is not a new wound. It is a reopening of a wound that was in that final maturation phase of healing. Okay, so super, super important. If you had an incision and 21 days later, it's still draining and it's red and it's tender, that's not normal. The body has not moved into maturation. So any questions? I'm going to pause here. You have inflammation, proliferation, and maturation. It's super important to understand what normal is. Okay, we're going to switch gears and we're going to talk about abnormal. There's a question that Wendy had. I'm looking at it on my Apple Watch because I can't see it on my computer, but I'm going to switch, Wendy, at the end of the call and we'll look at the question. So hang tight. So here's what it looks like in real life. We took a punch biopsy. We took normal, healthy skin. We cut it out with a round scalpel that we call a punch. And then we see the body progress from inflammation. See the redness around the edges? This second picture, that's not infected. Then there's redness here. That's not infected. That's inflammation, and that's normal. And now we're starting to get proliferation. We're getting granulation tissue. And then we have maturation, which is the final slide. Is that healed? Not for about 2 years. Okay? So you have inflammation, proliferation. Now it's healing from the edges and the bottom up. And then maturation, the final phase of healing. So what we're going to talk about today is when something doesn't go that way, because not every wound progresses in 24 days is scar tissue. So what happens when we have an infection? So Houston, we have a problem. Day 1, we see somebody's skin and it's got some redness on it and it looks like cellulitis. Day 2, it's looking really bad. Day 3, it's got blisters. Day 4, it's getting necrotic tissue. And by the time we get to day 10, that's a very short period of time, this person is at risk for not only losing their leg, but of losing their life, probably from sepsis as well. So things have a progression. You don't wake up one day typically with a wound infection, although you can't always see what's happening underneath the skin. So if you have a surgical incision, it could be 22 or 23 days later and you don't realize it because everything is good up here, but not so good down below. So there's a continuation of infection and it follows a progression. Just like this healing phase is a progression, the development of infection, particularly systemic infection, follows a progression as well. The question is, how fast is it going to progress? And this is the part where you need your doctors involved, you need your wound specialists involved, you need a team to be able to determine this, because it can happen like in an instant, within hours. Look at COVID. It can happen very, very slow, over 21, 22 days, like a hip fracture surgery that actually gets infected. It's not going to be infected on day 1, but day 20, it's going to be infected. So you have to know what you're looking for. And so when it comes to the continuation of infection, it starts with contamination. There is bacteria on all of our skin. Even when we go to the operating room, we put on betadine, we do antibiotics through the IV, we do everything we can preoperatively, perioperatively to prevent infection, but it still happens. So contamination is the start of it. That's why we make a lot of effort to try and prevent infection before they start. We test people for MRSA before they have hip surgery. We scrub their skin. We scrub our surgeons' hands. We wear gloves. We do everything we can to limit contamination, because contamination is the fuse that gets lit in an infection. So vigilance is required. Now, contamination means that our wound or our incision has bacteria in it. That's not a big deal, okay? Contamination is inevitable. There's no sterile wounds. There are no sterile urine. There is no sterile anything. Once it leaves the body or gets close to the exit of the body, it's contaminated with bacteria, fungus, viruses, microorganisms that are in the environment. Now, where things start to get a little interesting is where those bacteria do what bacteria like to do, or viruses like to do. They like to breed. It's fun for them. So they all get together, they breed, they multiply, and they do it quickly. Some bacteria do it faster than others. Some bacteria are very invasive and some are not invasive at all. But they colonize. So they reproduce and they grow, and they reproduce more and they grow. When they get to a point where there's so many of them, we call that critical colonization. That's where you have a local infection. That's where you have enough bacteria in a wound or in an incision that you're starting to get changes in the chemistry of the tissue. You're starting to get more white blood cells. You're starting to get inflammation, not in the first 4 to 6 days anymore. Now the inflammation comes back. So I had my incision. It was painful and swollen for a few days. And then a week later, it got painful and swollen again. Houston, we have a problem. We're getting critically colonized. We need to intervene early in critical colonization. Now, critical colonization will continue and happen, and then infection will spread. It will continue to multiply and grow like the movie Gremlins, for those of you that are as old as me. And then all of a sudden you have so many gremlins in the wound that they start going into the healthy tissue. And so now you get a cellulitis. That's what you see here in this infection. So you had this contaminated, colonized wound, and now you have this spreading infection. Now the infection is affecting the cells outside of the wound bed. This is a critical point. And if you don't catch it, it's going to get into the bloodstream, and that's what we call a systemic infection. The bacteria or the fungus or whatever has gotten from the tissue into the blood, and now somebody is becoming septic. So you can see this doesn't happen. You don't go from contaminated to septic. You go from contaminated to colonized to critically colonized to spreading local infection and then deep infection or sepsis. So again, you and I look at a wound and we go, is this normal? Is it critically colonized? Is it infected? I mean, I look at that and I might go, that actually looks pretty good. Some people might look at it and go, oh my gosh, there's pus in the wound. Do you see that white stuff, that yellow stuff? There's pus. Well, maybe that's not pus. Maybe that's fibrinous exudate or proteins that are causing wound healing. So this is why we need to do it together as a team. This is why you and Brandy and the PCP in the building and everybody has to be working together, because everyone has different parts of their scope and their license that can look at this and go, oh, that looks great. But if you're new to wound care, you might look at that and go, oh my gosh, we need to send them to the ER. There's pus in the wound and the wound is infected. So you just don't know unless you know. So I'm going to give you guys some, this is, if you could take any notes today or take a screenshot on your phone or on your computer, take a screenshot of this. And you can look it up online. If you Google nerds and stones, you're going to see this acronym. And this is important for PDPM as well, because when you have a patient, a resident that admits to your facility, if they have a chronic infection in their wound, your facility gets paid more, which is important because a chronically infected wound is going to take longer to heal, more nurses to take care of it, more dressings because it's going to exudate more, and more risk and more cost and more problems. So you should get paid more for an infected wound that's not infected. The problem is that infected or not? Who's going to decide? So here's how you can decide if a wound is infected. If it's a local infection, like superficial, again, back to this continuum, if it's a spreading, critically colonized, it's in the yellow, orange, but not into the red yet, it's going to be a wound that's non-healing. What does non-healing mean? Well, I had hip surgery and I'm supposed to have a wound that's not draining anymore because it's supposed to take 21 to 24 days and it's still doing it. That's a problem, okay? If it's been 3 weeks and your wound is still draining into your bandage, that's a problem. If it's been 3 days, that's normal. If all of a sudden the wound starts exudating more, so we had a little bit of drainage, but oh my gosh, now it's just so much drainage, whether it's pus or purulent or whether it's just clear drainage, Clear drainage can be a sign of infection, guys, because clear drainage is the body trying to flush out a pathogen. So we exudate out of our skin because we're trying to wash out our tissue. So if you were doing bandage changes on a maybe a diabetic pressure ulcer on the foot, and then you were doing them every other day, and then all of a sudden there's fluid dripping out of the bandage within 2 or 3 hours of putting it on, that is a sign that you have a superficial infection and maybe a deep infection. If you had red, friable, bleeding tissue, that would be like hypergranulation tissue, if everyone's familiar with what that looks like. So hypergranulation tissue is a sign of a superficial infection. If you're getting a lot of debris like that, this stuff on the wound, that creamy fibrinous protein, a little bit of it, but all of a sudden next week you come back and there's a ton more, that is a sign that there is infection. But let's say the wound didn't smell, but now it's starting to have a smell to it. So you can see now the acronym NERDS, non-healing, exudate, red, friable bleeding tissue like hypergranulation, debris, or smell. Some of that, if you're having those symptoms, you don't have to have all of them, but if you're having some of them, the literature tells us that you have a superficial infection in your wound, and you should treat it topically. You should put something on the top of that wound to try and keep it from getting deeply infected. Okay, this is key for our antibiotic stewardship. This is not culture the exudate, and then plan on putting them on IV antibiotics or putting them on an oral antibiotic. You might put an antibiotic into the wound, like a topical antibiotic or silver or iodosorb gel or some sort of topical antimicrobial, but you should not be thinking about treating this wound with antibiotics. Okay. Now, a deep infection is going to be the acronym STONES. So we had a wound and things were getting smaller, and it's not that it's just not healing now. Oh my gosh, it's twice as big as it was 2 weeks ago. When wounds get bigger for no reason at all, it's usually a sign that there's infection that's getting deeper into the tissue. And think about it, it makes sense. You had all these bacteria, they were in the wound bed, now they're spreading out and they're getting into healthy cells. Those are going to die and the wound's going to get bigger. So when wounds are getting deeper and larger, that's a sign that there is a deeper infection. When the temperature around the wound or the incision increases, not just the first 3 to 4 days where the inflammation is, that's a sign of infection. If you can probe or see bone inside of the wound, you have to presume that there's an infection until proven otherwise. Wounds that have exposed bone, you should be saying there's a deep infection, we got to do something about this. New breakdown, you have a wound, but now all of a sudden you're getting these satellite wounds around it. That's because the bacteria got into the capillaries and is now being seeded out to the skin next to it. So when your wound is breaking down and it's not because of moisture like MASD, and it's breaking down with new little satellite wounds or pustules, that's a sign that it's deep. When all of a sudden you have increased exudate, increased redness, and swelling all together, that is a deep infection, and that needs to be treated systemically, antibiotics, or their smell. So when you have these criteria of a deep infection, the stones, that's when you treat systemically. The goal is to treat it, though, superficially, if you can, before it gets deep. This is a really important slide. So I'm going to pause here and just see if anybody has any questions. I'll check the messages afterwards, but feel free to take yourself off mute and just let me know. I hope you're all still there. I trust that you are. Okay. So what does the state operations manual say about wound infections? Believe it or not, your surveyors actually have a tag and they have a line, and I just took it straight from there, that says how you should be navigating these waters of infection. They're not saying wounds should never get infected. That's not what they're saying. An attorney might say that, but anybody that's intelligent, yeah, I did say that. Write that down. Ryan Dirks, CEO, United Wound Healing, said attorneys are not intelligent. An intelligent attorney is going to say that, well, wounds get infected. The question is, did you intervene and did you do the right thing? because it's nobody's fault that a wound got infected. If you got a tag from a surgical wound that got infected, it's not because somebody in the facility took some bacteria, put it on their finger and shoved it into the wound and now that it's somebody's fault. It's not the case. But you have to have the documentation to support that you did the right things to try and either prevent the infection or to treat it early and prevent it from getting worse. So the State Operations Manual says, again, to your surveyor, that the physician diagnosis of infection. So guys, it's really key. Your medical director, your PCP, and Brandy, your wound specialist, have to be on board with this. One of the things that you have to do is notify them of a change in condition. So you don't have to diagnose infection. You have to notify them of a change in condition that could be a suspected infection. Okay, that's your job, is to notify and document. I told Dr. Smith that there's increase in redness and it's day 14, and I know that increase in redness should be done by day 5 or 6, okay, the inflammation phase of healing. So you're going to document that. So it also says that a wound, let's get rid of pressure injury ulcer, a wound is based on the resident's history, the clinical findings, so how long ago did they have the incision, how long ago has the wound been there, and presumably a wound culture. We're going to talk specifically about cultures in a minute because I'm not a culture fan anymore. But this is straight out of the State Operations Manual that your surveyors read. Pus, slough, or necrotic tissue should not be cultured. I didn't make that up. CMS knows that that's not the standard of care. You have to culture healthy tissue. Okay, you don't culture dead tissue because all dead tissue should have bacteria on it. The bacteria are trying to eat up that dead tissue. So you don't want to culture the clean stuff or the dirty stuff. You want to culture the clean stuff. And this is what your surveyors are looking for. Did you culture right? Findings such as an elevated white count, bacteremia, sepsis, or fever may signal an infection related to a wound. Let's just change it to surgical, pressure, whatever. Or a coexisting infection from a different source. Okay, so lab findings like CBC, WBC, SED rate, all that stuff your PCP is going to be doing and our wound care provider is going to be doing to document infection. The treatment of infection will depend on the type of infection present. That makes sense. So this is really right out of the State Operations Manual. So what happens when you're being asked as the nurse to obtain a culture? We'll talk about cultures and the problem with cultures in a minute. But when you culture tissue, there's a specific way you have to do it. And you have to culture healthy tissue. And you want to do it in a 1 centimeter area. 1 centimeter is about the size of the tip of your pinky. Okay? So you don't want to swab the whole wound. You want to pick a healthy area in the wound. And you want to obtain fluid. Okay, the reason that the tip of the culture is cotton is because it's going to soak up fluid because fluid is where the bacteria lives. So you're not trying to collect junk off of the wound with a culture or pus. You're trying to collect the juice, for lack of better words, that comes out of the healthy cells where the bacteria has been involved. So we use a technique called Levine's technique where you press the swab into the healthy tissue and you turn it and you spin it in a 1 centimeter area. I got the juicy comment. Thank you.
All the way up. I can't hear a word the guy's saying. About wound healing. I can see his slide, but I don't know what he's saying. There, he fixed it. I don't know what this guy's trying to say.
On the audio,
this video keeps
I'm kind of getting whatever you're saying kind of coming in and out. Could you, was it a question? Could you repeat that for me? Okay, maybe it's just some background noise. So I'll move on. If you have a question, we can cover it at the end. So you can see you're going to spin the wound culture swab in a 1 centimeter area. I don't know why Lacey can't hear me. I was just looking at that on my Apple Watch. Sorry, Lacey.
can hear him. I don't know what he's saying.
Can everybody else hear me?
She's in the
I can hear
kitchen
you.
pouting.
Okay,
Yeah.
good.
Yeah,
I can hear you.
Okay, good. So let's talk microbiology a little bit. This goes back for a long, long time in history. So microbiology is nothing new. Cultures are nothing new. However, there's a better way to do this when it comes to wound infection. And this is what I'm going to tell you a little bit about today. Brandy can tell you and teach you a whole lot more. Maybe you already know this from working with Brandy, or maybe you don't. So in medicine, our job is to diagnose and treat. So that is the job of medicine, to be able to say, here is your condition or your bacteria that's causing the infection, and here's a specific treatment. The more accurate your diagnostic tool, the better you can treat. So way back in ancient times, we grew cultures on a medium, and the microbes grew out, like you can see on the left. And we would put it in a little heated petri dish. Many of you did this in high school and maybe even in college. And this is how you see, or we used to see, and people still do, what is growing inside of a culture swab. There's a better way of doing it, which is to look at the DNA. So not everything you swab grows, okay? And the timing that you get the sample to the lab to start the growing process, some bacteria is already dead. So only living bacteria can grow, dead bacteria can't. But dead bacteria still have DNA. What we know now in wound infections particular, that the bad guys, the bad gremlins, the bad actors, they often die before the lab even gets the culture, unless there's a lot of them. If you have a really lot amount of bad actors, you're going to have probably some of them grow. But what happens a lot of times in wound cultures is we culture the tissue and the bacteria grows out only what survived on that little Q-tip before you sent it into the lab. So a more accurate way to figure out what's growing in a wound and to come up with a better treatment is to do a DNA analysis of it. So we move from a focus of pathogens, the things that are alive and wiggling and crawling, to understanding a terminology called biofilm. So planktonic bacteria are the single cells you see on the left, and those are little purple balls. They're alive and moving around. That's not what's on the surface of a wound incision or inside of your resident's chronic wound. It does not look like that. This is inside of a chronic wound or a wound incision. You see all different types of bacteria, right? You look like the one that's got like the honeycomb cereal. You got hyphae, which are little tiny balls and little sticks. Those are fungus. You have strep, you have staph, you have all kinds of bacteria all living together in this soup that we call a biofilm. So a community of bacteria is actually what we're trying to deal with. We're not doing a single planktonic bacteria. So a traditional culture is going to grow out the single planktonic bacteria. Biofilm is very different. And so we have a different test for biofilm. The things that are in chronic infections aren't necessarily what is growing in your swab when you check it. So a DNA analysis versus cultures, here's just a study, is if you have 16, you had 16 DNA samples from a wound, and then you had 16 cultures, this is exactly what I was telling you about. We do the DNA test. We found 48 of 51 of the staph breeds or staph types identified. A traditional culture, most of them had died before they could actually grow in the petri dish. Pseudomonas, 32 out of 51 were identified with DNA. 8 out of 51 were identified with Pseudomonas in the culture. So I don't know about you, but if I have a wound infection, particularly like a diabetic foot ulcer, and I might lose my toe or my leg because of it, I don't want a culture. I want you to tell me what is actually growing in it with DNA. So DNA sequencing is definitely the more appropriate thing to do when it comes to treating a chronic wound infection. So how this affects PDPM is if you have a wound that you believe is infected, you can swab that. Within 24 hours, you don't have to wait for the test to grow bacteria or not grow bacteria. The DNA will tell you, is there an infection or not? So really, this is the best way in a nursing home to deal and manage with infections. The only problem is everybody still really likes cultures because it's the old way of doing it. And then you didn't hear this from me, but hospitals and labs like cultures because it's the cheapest way of doing it as well. They make the most money off of cultures. And if you talk about the money side of things, if you do a traditional culture, I know your administrators going, okay, how much is this going to cost me? If you do a basic culture and sensitivity, and you do that for the aerobes, like staph and strep, you're going to be paying about $50 to $70. If you want to know the anaerobes, which are just as important, actually, those are even typically more volatile and more aggressive than your aerobes. Those are going to be an additional $160. And then if you want to know what's growing in the fungus, you're going to pay a lot of money. So cultures can get very expensive. If you do a DNA test, most labs are around $199. And about a year ago, when I put together these slides, nobody knew anything about DNA testing or PCR testing. But when you do a COVID test, where do those COVID tests go to now? They go to a PCR lab where they check the DNA. They don't do a culture, a viral culture, that's outdated. They do a PCR DNA test. So I know this sounds like maybe a little foreign to you all, and you're like, why is he, so anti-cultures? Well, people have moved away from cultures already, and COVID just proved it. So I'm going to pause and stop there, go back to where I can see everybody's faces. Hopefully I started a conversation that was helpful for you guys. Let me go through and just read real briefly the list of questions. Stop sharing my screen for a moment. Somebody said, I love the National Pressure Injury Association. Me too. I'm just mad that they changed their name from ulcer to injury, because then attorneys sit there and go, oh my gosh, people are injuring our patients and we can sue them. So that was not my favorite part of them changing their name. Why have I heard it's same wound only if it opened again in 60 to 90 days? I've never heard 60 to 90 days. Really, the focus on if the wound is reopened again should be based off of that maturation phase of healing, and it takes 2 years. So if it's me or Brandy, your wound care provider, we're probably going to say that wound is still maturing up to 2 years, and if it reopens, and it doesn't reopen from another reason. So like, let's say you had a diabetic foot ulcer and now you get a DTI in that area, that's a different type of wound, and that should be coded differently on MDS. But if you have a diabetic foot ulcer and it opens again 2 years later after it was scar tissue, it's the same diabetic foot ulcer. I love Juicy, yes. Lacey can't hear. Okay, so I think I got all the questions. I'm gonna just pause there and let everybody ask questions that would like to.
So I wanted to talk to you about the DNA testing. I agree with you fully on that. The return on it coming back is so much quicker. The accuracy is so much better. It's all around. We at my clinic actually would do 2 tests. We would do a regular culture, send it to our hospital, and then we'd do a DNA test. And a lot of times we'd come back with MRSA from the DNA test and not catch it from the hospital. So the accuracy was tremendous overall. And there are some companies out there that the cost on the DNA is also pretty darn, it doesn't charge the patient at the end of the day.
Yeah, Judy, you're right. And Brandy actually should be carrying the kits for our microgen tests with her when she comes to your facility. So if you have a patient that needs a microgen test or a DNA test, it should be very easy to do. Anybody else have any questions? Was it helpful to understand that infections have a progression and that you have to watch for those signs along the way, and that it's normal for the first 5 to 6 days to have redness and swelling and pain and drainage? But if that happens 2 or 3 weeks later after a surgery, that's a problem?
Yeah, I feel that the description of the wound and the phases of healing, it's been a long time since I've had a wound class, and it's been a while since I've been in nursing school. I thought that was very helpful.
Awesome.
I have a question.
Yeah.
How do they do the DNA testing? It's not a swab, right?
It's it can be done in a lot of different ways. The main thing is that you get either fluid or tissue. The best way to do it is actually to cut some tissue out, whether it's some subcutaneous tissue, granulation tissue, slough, bone is good. Toenail clippings, if you're treating somebody's toenail fungus, you can send that in. So the best thing is to have something that has the DNA on it. But as you guys know, you can get DNA off the swab and, you know, inside of somebody's mouth or off of your fingers and skin cells. So DNA is very easy to collect.
Thank you.
It's Wendy. It's somewhere in the RAI manual, at least at some point in the past it was, that I heard about I don't remember if it's 60 or 90, about whether something's a new wound or a reoccurrence of an original wound. But
yeah, I don't remember.
I did hear you say that.
That was, yeah. I've always clinically as a provider just said that, so when I say that a wound is closed, so let's say we're treating a stage 4 pressure ulcer on the sacrum together, and now we're super excited because it's all scar tissue. That day in my documentation, I'm going to say that this stage 4 pressure ulcer has been treated for 24 weeks. There is a measurement of 0 by 0 by 0. It's all scar tissue now. There's no drainage. And the wound is now in the third and final maturation phase of healing. That's typically what I say. And then sometimes I'll put a comma. This wound is going to continue to heal and will continue to have the risk of reopening for the next 1 to 2 years. Typically what I would say with that in my documentation. Do you guys see the correlation between wound care? If you're a cardiologist, I don't have a stethoscope in my office here, but if you're a cardiologist, you have a stethoscope, right? That's how you do your job for the most part. If you're doing wound care, whether you're a wound care specialist, a wound nurse, or a floor nurse that has to document what you see, or a CNA, this would be a great class to do with our CNAs as well, is your stethoscope is your eyeballs, right? So you got to train your eyeballs just like you have to train your ears with the stethoscope. You have to train your nose and your hands in wound care. So cardiologists listen with their ears, wound care people look with their eyes, and you have to train your eyes. So that's why it's really helpful to round together with Brandy, because Brandy's going to see 40,000 wounds in the next year. All of our providers, we see about 40,000 wounds a year. So just like the bank teller that's counting money and can tell, oh, this bill feels a little bit different than this one. They both say $10 or $100, but this one's counterfeit. That's how people that count money can tell counterfeit money. They count so much money over and over again that when somebody slips a fake one in, they know. So that's why not only is wound care a visual sport and you have to do a lot of it, but your documentation is so important. You don't have to have the right words. You don't have to have the words like erythema or epibole or exudate. You can just flat out say redness, pain, swelling. You don't have to have all the words to describe it. You can just flat out say, this is what I see today. And that's where the surveyors get us every time, guys, is they just, there is not a documentation that says there is no redness today. There is no pain. There is no drainage. That's what's missing. It's super simple. You don't have to be an expert in any of this. You just have to be very diligent about documenting every time you look at somebody's skin and going, I checked the incision. It's not red. It's not tender. Or it is red and tender, but the incision happened 5 days ago. That should be normal as expected, but I'll let the PCP know. I'll let the RCM know. Those types of things.
Perfect. Thank you.
Does anybody have any other questions?
I just want to thank you guys because I hope this was helpful for you guys. This was really helpful for me. If we're all being honest, this whole COVID thing has been really hard for human beings. And the work you guys are doing is incredible. And I'll be honest, guys, as CEO and wound care provider, I'm not out seeing patients very much, and I'm definitely not out educating nurses. And I love doing this with you guys. And so this was just as important for me to be able to do today as it was, I hope, for you guys. So thank you for putting up with me for the last hour. And I hope to be able to do it again soon.
Well, thank you, Ryan. This was a really good refresher for some of us and new information for others. So thank you.
Well, great. Anytime you need something, you can reach out to Brandy. You can reach out to us. We're here for you guys.
Okay, thanks.
Bye.
Thank you so
Bye-bye.
much for the presentation.